The next speaker I'd like to introduce is Scott Barnhart. Scott received his doctorate degree from the School of Medicine and Health Sciences at George Washington University and then completed his residency here at the University of Washington. He's a professor of medicine and environmental and occupational sciences. He's been the medical director of Harborview Medical Center and the associate dean for clinical affairs at the University of Washington School of Medicine since 1999. And when I came here, one of the things I was amazed by was the efficiency, which you heard mentioned, at which Harborview runs. And Scott really coordinates all of that as the chief medical officer there and the medical director. And so I expected when I met Scott to meet this really tense, uptight human. And in fact, he's just somebody that with grenades going off everywhere just remains completely calm. He's exactly the type of person that you want at the helm of an organization like that. He also has a degree in public health and community medicine from the University of Washington, and he's conducted extensive research related to occupational environmental health. And so he's known nationally for his research, but he's also just an amazing first-rate physician and administrator. Now, I don't know what the odds of this are, but he also had his picture with his car published in the PI in Autobiography. And so I don't know if that's how we selected these speakers or not, but I would tell you that it's not. And Scott had gotten so many criticisms about the quality of his motor vehicle, he actually said, "I'm going to stand proudly by it," and send it to the PI. And so again, I think what is really wonderful is that the people that we have leading the organization are also wonderful folks. So Scott Barnhart.
Thanks, Norm, for that very kind introduction. I have to say, when I put that picture in the PI, they always say, well, what's the name of the car? And so I said, La Petite Camion. And Seattle being an erudite city, it wasn't very long till I got a letter sent to, they found me at Harborview and said, it's Le Petit, not La Petite. And, you know, but that's, I'm in medicine because I clearly couldn't be in English. Now, I always sort of hesitate to follow somebody like Dr. Mengert, who, you know, is truly, I think you have seen, one of the masters in teaching. But I want to just, as he says, we have to ask a few questions, and mnemonics are an important thing. And so I'd just like to ask Terry and anybody else, what does the mnemonic, never lower Tilly's pants, mother might come home, mean? Terry? How about anybody else here? Well, see, you're all good to be here because there's a lot to learn, and that's how you remember the bones in the hand if you're an internist. So I have actually the easy job because I really get to talk a bit about Harborview, and you know, for me, there's nothing I'd rather do more than to take time and sort of share what goes on at Harborview. And when I was asked to do this and sort of talk about the safety net, I thought maybe what I would just do is paraphrase, since we're not allowed with HIPAA, and I think out of respect for patient privacy, you know, we try to be very, very confidential. But I would share with you in a paraphrased way what a day in the life at Harborview is like, and just give you a sense of who is coming into Harborview on any given day. And Harborview, as I think most of you know, is our level 1 trauma center for the entire region, but it really serves a remarkable range of people. It serves people from all walks of life. Many people come there for elective surgery. There are many people who are injured who just all of a sudden arrive there really having no choice. It's just they're in a bad accident and they end up at Harborview. And to give you some examples, one of the first ones I'll just run through is with Helen Jones, a bank president, worst headache of her life. And I can tell you this is a very common sort of complaint that we see at Harborview. And as Medic 1 will do, they'll call into Harborview, Medic 1 to Harborview. We're bringing in a 55-year-old woman with a headache an altered consciousness. They arrive at the emergency room. They get an emergent CAT scan. One of the unique things that we have is you literally go from the resuscitation room 8 feet across the hall right into the CT scanner. That pairs our radiologists and our emergency room physicians working closely together. We can get a CAT scan within minutes. Blood is in the ventricles, and there's an immediate request to call neurosurgery. That's patient number 1. Patient number 2, patient over in Eastern Washington. And Dr. Wells says to them, "You've lost a lot of weight, and you've got quite a lump sitting there in your neck. You'll need a biopsy of this. I'll refer you to a neck surgeon." Mr. Thomas, as he calls to get in and get an appointment, "Hello, my doctor referred me to Dr. Z. Excuse me, my insurance? I don't have any insurance right now." And Dr. Z's staff, "I'm sorry, Mr. Thomas, but Dr. Z is not available to see you. Where can you go? Try Harborview." This is a story that's repeated many, many times each day. So for Harborview, we take every patient one day at a time. And as I think you've heard earlier, we serve an enormous geographic area. We serve the largest landmass, a quarter of the landmass of the United States. And we see patients from all of this. The majority of our patients come from the city of Seattle, whether they're inpatients or outpatients. But our mission is really to serve all of King County and to be a regional referral network for really the entire WWAMI region. And that is where our patients are coming from. And here, just to give you a quick example of where some of the patients come from, this actual slide here shows where the Medicaid and self-pay patients come from. And when we look at the and underinsured patients, they either fall into Medicaid, which is a federal state insurance program for those who really have very limited resources, or for many people, in particular now, it's the working poor, they have no insurance at all, and they're what we call self-pay. That's really a euphemism. Self-pay means that you don't have money and you're not going to be able to. And as you can see here, we see patients from all around in Alaska, whether it's, and pretty much you just look at those small population centers throughout Alaska, Southeast Alaska, and then it stretches all the way into Montana, some into Wyoming, into Idaho, down even into Oregon. Very common to have people come in and say, they've driven up from California looking for care. And then, of course, throughout Washington State, we have an enormous number of patients who are looking for care, knocking on the door, trying to get in, and they eventually get to Harborview's doorstep. We also are really what we call the no wrong door. And so a patient who presents emergently to any hospital in the region, if they need care, that emergency room will call us, and the patient will come to Harborview without delay and without any barriers such as looking at their insurance. What we do have in terms of the all encounters, and this, I'll just go through these math very quickly. This again shows for all encounters where the patients come from, and we really have patients that are drawn to Harborview from throughout the entire Western United States. So looking at another example of a case, and this one was very poignant. It was right around the holiday season, and I think it really exemplified some of the challenges that patients are having outside. And here we have a woman, Mrs. Pearls, a 65-year-old woman who developed a problem with her hip. 15 years ago, that hip was replaced, and for the last 3 months, she's had problems with it, and she's been trying to find a physician who would actually, the parts in that hip were broken, and they needed to come out and needed to be replaced. And she really has been shopping and looking for physicians, and that's what people do. People without insurance go from place to place to place trying to find a place where they can actually get care. And this is not a small problem where someone, you know, they're going to get better. This is a broken hip that they need to get replaced. And so Harborview maintains a transfer center for, in particular, acute and emergent care. And as I said, for emergent care, we'll take anybody and we'll provide them that care. And you can see here our transfer center. They answer the phone. If you call the number and say, Harborview Transfer Center, how can I help you? Yes, Dr. Benson. Let me connect you to our emergency department. Dr. K, Dr. Benson is on the line. Dr. Benson, I need help for this patient, and I can't get it locally. We've been trying to find a surgeon to remove these broken hip pieces for several months. Dr. K, we'll take care of her. Transfer center. Dr. Benson, let us arrange transportation. And that is a very typical story. We're the no wrong door. A physician has a patient, they can't get care, it's an acute problem, it shouldn't be left to find an eventual solution. It needs to be dealt with right away. We bring those patients in emergently. Another case, Airlift Northwest, calling to the trauma doc. The trauma doc is the person in Harborview's emergency room who stands ready to talk to all the emergency vehicles and to give them instructions and to also receive the information so when that patient hits the door, we're ready to take care of them. So Airlift Northwest to trauma doc, we have a 4-year-old girl hit by a car, arrival in 5 minutes. Every single day we're seeing this, and we do about 6,000 trauma cases now a year at Harborview. So Harborview really, you know, is a hospital of choice for patients from all walks of life. But most importantly, we're the no wrong door for the community. We're ready 24 hours a day, 7 days a week. Another area that has really challenged both hospitals and the medical professions is increasingly physicians are saying, I don't want to be on call. I don't want to be on emergency call. I want my schedule to work during the day, and I'm going to see the patients and provide for them on an elective basis. I don't want to be on call. So many hospitals no longer can maintain a full range of specialties, you know, which includes having internists, cardiologists, surgeons, orthopedists, neurosurgeons, hand surgeons. They're unable to do that. And when that happens, and these hospitals have a patient that presents with these problems, you know, the first call they make usually will be to Harborview. When we look at Harborview, we have very high levels of expertise. We maintain those as available at all times. We have 370 beds, and we have now about almost 20,000 admissions over a given year and about 350,000 outpatient visits. We also have a number of centers of emphasis where we really have tried to focus our expertise, and they include centers of emphasis around trauma, burns, HIV, AIDS, and STDs, the neurosciences, the mentally ill and medically vulnerable, and finally, reconstructive surgery and rehabilitation. To give you a quick run-through on some of these, in trauma, we're the only level 1 trauma center in the entire WWAMI region. We do 6,400 cases a year. We have almost 90,000 emergency department visits, and about 4,500 patients are transferred from outside facilities. We are the regional burn center. We are really the only burn center in the region, and there are 500 patients that come to the burn center each year. And along with the care that we provide, there's cutting-edge research in areas such as how to apply artificial skin that have really revolutionized the care of burn patients. In neurosciences, we bring together many disciplines: neurosurgery, neurology, neuroradiology, epilepsy, psychiatry. We have a Joint Commission for Accreditation of Hospitals accredited stroke center, and we have a lot of unique technology such as the Gamma knife that really allows for bloodless surgery for tumors that are located deep within the brain. We also take very seriously our mission to serve the indigent, to serve those who have really no place else to go. And we have a center of emphasis around the mentally ill and medically vulnerable. These are, to give an example, patients who have severe mental illness, who often will have also diabetes, renal failure, substance abuse. Many of the homeless you see fit into this category of patients, and we provide them with very unique services. We have 61 inpatient psych beds, we have psychiatric emergency services for emergent problems, and a wide variety of outpatient services. We also have a center for advanced reconstruction where we take both complicated reconstructive surgery problems and pair them with not only the reconstruction, but then the rehabilitation needed to get those individuals back on their feet. Our Center for AIDS, STD, and HIV is a very unique center. It's one that really started now nearly 20 years ago, just when the HIV epidemic began to be recognized. It has been a pioneer in really developing unique treatments that have prolonged and converted AIDS from what was in the mid-1980s and 1990s to a fatal disease to now one that is a chronic disease. We take care of the largest number of patients in the Northwest. We do a great deal of research, and this group, this center, is doing an enormous amount of work globally to help treat and prevent HIV transmission in the industrializing world. We also serve as the disaster control hospital and really partner very closely with King County Public Health. And so if there is a major disaster, and that could be anything from pandemic flu to a major seismic event, Harborview will serve as a central coordinating center for hospital resources in the region. And this provides, I think, a very important resource for the community. We also do a lot of education, and just last week ran a major conference on pandemic flu. And if you were to look at the New York Times in the last couple of days, you'd see they'd say, well, there are two cities that are prepared. New York City and Seattle are really the two cities that are felt to be even close to beginning to be prepared to deal with pandemic flu. And it's part of, I think, Harborview's and public health and many other partners' roles that has helped move us into that position. The hospital has a very clear mission, and it's to provide and teach exemplary health care. In the clinical care, we try to serve the indigent. We take care of trauma, burns, STDs, the non-English speaking, among others. And there's an enormous focus on teaching. We're one of the two main teaching sites for the School of Medicine, and there's tremendous focus on research within our institution. The hospital is owned by King County, and we have a unique model. The hospital is owned by King County. King County and the citizens of King County have very generously provided funds to build the buildings at Harborview. The hospital itself is run by the University of Washington and the School of Medicine at the University of Washington, and importantly, does not receive operating funds from King County. That makes us quite unique. Most county institutions have received operating funds, and Harborview Medical Center does not receive operating funds from King County. So we get very generous support in terms of building the buildings, but this is a hospital that we work very hard to run very efficiently and have been able to do that and to maintain the hospital in a very financially stable situation. Let me just talk a little bit about charity care. Harborview provides 28% of all the hospital charity care for the state of Washington. This is an enormous proportion and one we're proud to really be able to do. And as you can see, and they always have these data are always a little bit late, but in 2002, that represented 55 million. And so we far exceed, in terms of charity care, any of the hospitals that are in this area or any place really within the state. One of the challenges I think we all face, not only at Harborview as a community, but also as we look in Washington State, you can see that for Harborview, the amount of charity care that we're giving is going up very rapidly. And here it is, going from 27 million in 2000 to 93 in 2004. We actually went even higher last year, and now it's begun to level off. These are really extraordinary levels that are not sustainable. And it is important that we identify ways to address, I think, the real crisis of healthcare funding and financing that we're all facing if we're to be able to ensure access for all of the citizens, not only within King County, but Washington State and the WWAMI region. What's in the future for Harborview? Well, Harborview, and I welcome all of you to come up and take a look at it. It's really your hospital. We are really a tremendous asset, we feel, for the community. We're here to serve the community, and we look forward to input. Right now, we're in a very extensive, almost $300 million building program. And in terms of that building program, you can see two buildings here, and the building that is on your left is the new inpatient expansion building. And then on the right, we have what we call the 9th and Jefferson building. The inpatient expansion building will have 8 ORs and 50 additional beds and additional support spaces. And then in the 9th and Jefferson building, we'll actually move our center of emphasis for AIDS and STD there, along with pathology and the medical examiner. And this will, when it's completed, give us, I think, one of the best facilities, and actually all of the clinical parts of the hospital will be less than 10 years old. And so we really will be in a very good position to provide care and to serve the community, not only in King County, but throughout the Northwest. So with that, I thank you for your attention. Thank you.
Very nicely. I think we talked about, really a purpose, a will to meaning, and having an impact. And I think we conveyed, hopefully, why we're in it, and some of the nice folks that are committed to that. I think Dr. Robinson gave a nice overview of UW Medicine and some of the ways it has an impact in multiple domains. And then Dr. Barnhart talked about the strength of Harborview and the challenges of medicine. What I'd like to do is to give you all a chance to ask questions. And I'll invite up our three speakers, I'm already here, and open it up to any questions that you might have. And I would ask that, again, we're all here to learn, so don't hesitate. No one will turn around and see who's asking the question. So if you want to go to the microphones and ask questions, please do so. If you guys want to come up, that would be wonderful.
It's so unusual for Norm and I to have extra time. And last year, one of the complaints, and it was a legitimate complaint, is that we didn't allow enough time for questions and answers. So this is a chance to free-form it.
Yes, please.
So if Harborview gets no funds from the county and it's spending $93 million a year on charity care, where does the money come from?
Well, the money comes from a number of places. The first thing is that Harborview actually serves what we call a balanced payer mix. So we have, of the people who come to Harborview, about 38% have commercial insurance. And with commercial insurance, we actually get a little bit ahead there. We also get some money that there are state and federal programs called disproportionate share programs that provide some funding if you see a large proportion of what we call Medicaid patients. And so we get funding there. We also try and run the hospital very efficiently. We run fairly full, so we're all the time trying to use every inch of capacity there. I think Norm knows this because we run them right through the radiology department, and he's got to have the attendings to read them. So we are trying to run at a very fast level. And then lastly, we have what we call process improvement. And every year, we try and strip out roughly $15 to $20 million of expenses. So when we look at our patient care, we want to have it be high quality, safe, effective, but we also want it to be efficient. And between all of that, we usually have a margin that is about 1%. So we come out with a sort of $4 or $5 million margin. That is a razor thin budget. You know, if you have a $500 million budget and you got to come in at 1%, we're pretty close to the line every year. But that's our goal. We're not in this to make a lot of money, but we do want to absolutely maintain and have the very best quality of care.
Well, all of you discussed the crisis in medical care, and I guess my question is, could each of you or some of you tell us what your 3 best recommendations are in terms of what to do about the crisis in medical care?
Oh, boy.
Larry?
I can't problem solve that effectively right now with my current state of knowledge. But I would say one thing that strikes me as amazing is, unlike most industrialized nations across the globe, health care for Americans is not considered a right in terms of how we handle it. And yet I think most of us as Americans would say we believe health care is one of our fundamental rights as a people. So somehow that means that we need leaders in Congress and leaders in medicine and health care to somehow sort that out so that we can do a better job than the job that we've done. Now, part of me, it's a mixed bag, because part of what we do is absolutely superb and cutting edge throughout the world. But the cost in that, in terms of our people, has been significant in the underinsured and the silent voice, the people that our society has a tendency to walk all over. I do think better minds than mine are wrestling with this right now. I think the key point is to realize that what we have right now, despite its many excellences, is unsatisfactory.
I wanted to say a couple of thoughts. One is, well, why are the costs so high? And well, there could be a couple of reasons for that. Either we use too much health care compared to other countries because our costs are higher, or maybe the things we use are too expensive. Well, why would we use too much? It might be that we do things that are not really helpful or proven to be helpful. There are a number of procedures and drugs that we use that I think maybe don't benefit the patient. And I think we have to start looking at that and weeding out those things that really aren't effective but cost a lot of money. And then why are things so expensive? Well, you start looking at the pharmaceutical industry, the device industry. Why are things more expensive here than they are in other countries? And you got to work that down and figure out, why are we paying more than other countries are? And then the problem that Scott brought up is many people who are uninsured, they're at that lower socioeconomic level where they're the working poor. They don't make enough to buy health insurance. Their employer doesn't buy them health insurance, and it just doesn't seem fair to have it go that way.
And I think one of the issues is, as we talked about, 29% of healthcare is delivered by academic medical centers, but they provide 80% of the care to the uninsured. And I think that we do have hospitals nationally that are in it for the profit, and they turn patients away. So I would like to see people get back to core values, which is we went into medicine to take care of people. I think if everybody, all the hospitals, actually chipped in and did a component of serving the underserved as well as the patients that can pay, I think that we would be much better off as a nation.
I guess if I could just sort of give, and I think this is all personal opinion up here, but if we look at, the United States has made a very clear sort of decision that we want to maintain choice for those people who are insured in terms of their care, and that we'll take about 15-20% of our population who are uninsured and leave them out of the system. That's a choice that really no other Western or industrialized nation has made. I think the first thing is that we ought to really think hard about, is that the right choice, or should we change that and say, really, we should have universal access as a primary goal. The second, and that would mean that we would have to give up some choice. All of us in this room would have to give up some of a choice. So that would be number one. Number two, I think we ought to look, are there potential different models in there? I mean, we have an extraordinary complex system. I don't spend most of my time actually on sort of the things I'd like to in medicine. I spend much of my time all around, it's all about regulation and trying to move all the paper and dot all the I's. There are simpler systems, and they're usually single payer systems that eliminate and get rid of a lot of that. And then thirdly, I think we should be looking for the potential of disruptive technologies. And there'll be a lot of debate, but there are things such as, information technology which can be used. And the best example is the VA. If you go to the VA 15 years ago, people would have said, that is not a high-quality healthcare system. But the VA has changed its perspective, and they are there to serve the veterans, and they have relied very heavily on information technology to deliver what now I think most people feel that they are one of the best high-quality and efficient healthcare systems within the U.S., and we ought to be looking at those kinds of models. There are solutions to these challenges out there.
Dr. Robinson, you stated that the UW is number 2 in the country as far as the funding of medical research. To what extent does medical licensing play a role in the funding of the medical school? And how do you view the licensing as it's used by the pharmaceutical industry at large with the technologies that we develop at the UW?
Good question. So I assume that you're asking about technology licensing when we develop new technologies.
Exactly, because we develop an amazing amount of new breakthrough technology in medicine. And to what extent does that play a role in the funding of the medical school now and as you see in the future? And how do you view the way that these are applied by the pharmaceutical industry?
Right. So out of the $600 million, the great majority of that is federal funding. So it's funding from the National Institutes of Health, Department of Education, a little bit from National Science Foundation, some from Centers for Disease Control, and that forms the majority of funding. There is some funding from manufacturers and pharmaceutical companies, and those are usually what they call clinical trials, industry-sponsored clinical trials. And so that's where a company will help fund us for doing a study, and they would fund us per patient to try to collect the appropriate number of patients. And of course, we have to have an investigator that believes that it's a good study and appropriate to ask their patients to be in it. And that funds a relatively small part of the $600 million. It's probably 10 million or less. And in terms of the licensing of new technologies, if that's done by a faculty member at UW in their official job at UW, there is an agreement whereby the university gets a small amount of the royalties, and those royalties are then put back into new research projects, new pilot research. We have what's called the Royalty Research Fund, where a faculty member can apply for these funds, get some pilot data, which would then form enough data to apply for a bigger grant and do a more serious project. Norm, you're probably more up to date on the licensing. I don't know if you want to say a few words.
You may be getting at a couple of issues. One of the things that some other centers, like perhaps MIT, has done is tech transfer as a way to generate substantial revenue. And I think that we've actually come a long way as a medical institution. In probably the last 5 or 6 years, our Department of Bioengineering is the number one in terms of technology transfer. And if you look at, for every dollar invested in research at the U, it brings close to $300 back into our community. So if you look at a return on investment analysis, it's enormous. And trying to help get a better understanding of that business proposition when the state looks at what does it prioritize, well, in these financially difficult times, that's a pretty good return. Another point that you make is the conflict of interest potentially with pharmaceuticals and the potential dollars that can be made. And I think one of the things that Larry's office, Vice Dean, the Dean, has put a great emphasis on is that we have to be very careful about what the conflicts of interest are if we're going to be fair in the research that we do with our patients. So I think that we're uniquely cognizant of it. And I look forward to, you know, the next 5-6 years as we increase kind of the return on some of the technology that we bring into the community. And Seattle is actually a very unique environment where, as you know, entrepreneurship is really emphasized. So, good question.
You mentioned that research funds cannot be used either for teaching or for patient treatment. How about if you want to do some sort of a study? For example, if you want to be part of a study, say trying aromatase inhibitors on premenopausal breast cancer patients, you know, that's probably for the women involved going to involve visits to oncologists, discussion, a lot of what is care, but it's all part of a research study. And my question is, can research funds be used for that kind of thing, or do they have to, or do you have to come up with funds from someplace else for that? I.e., could lack of those research funds ever limit the kind of clinical studies that could be done here?
Yes, so I think what I was trying to get at was that the research funds, particularly those from the federal payers, but really all the research funds, can only be used to fund the research project that was proposed to the granting agency. And so if it's a trial of a new drug or a new therapy, then those research funds can be used to support the additional work that's put into enrolling the patient and doing the tests that are required for that therapy. But what's problematic is, in terms of how do you pay for uninsured care, is that you can't hire someone, put them on a grant, a physician on a grant for part of the time, and during part of that time ask them to see patients for clinical care. And you can't use those dollars to support teaching, to have the person do teaching because they're supported by a grant. It really has to fund just their work on the grant. And it can fund parts of patient care, but it won't really fund usually a whole episode of care. If someone comes in with a new disease, it's not going to fund the whole treatment. It's going to fund a little piece of it that's needed to do the research. I don't know if you fellows want to say.
Yeah, and I think that the point of that is then that whereby, you know, what good is it to have an academic medical center in our community? I think the benefit is it does access people to some of these studies, no question about it. The challenge then, though, is that there's also the underserved component, which we have to address as well. And you can't do a funds transfer from research. You really are limited to focusing on the problems that the funding went to.
I understand. So basically, you could see her for, in the example I just gave, for example, the physician on in the program could see the breast cancer patient to get her enrolled in something for the aromatase inhibitor, but couldn't talk to her about radiation, for example, as part of that.
It would have to be funded a different way, that's right.
That's what I mean. It'd have to be.
That's right.
Okay. Thank you.
Thank you. Sure. Last question, please, or last two questions. We've got plenty of time. It's all good. Yeah, please.
My question was, what makes Seattle and New York better prepared specifically for the advent or the possibility of pandemic flu? And what are the plans?
Well, I think I can't speak for New York. I think what has worked well in Seattle is that we have a very strong partnership between King County Public Health, Harborview, as well as the other healthcare institutions in town. There's been a lot of planning that is really looking at if we have, say, pandemic flu, how are we going to deal with that? The actual way that pandemic flu will be handled is not completely certain because we won't know until it actually begins to show up. And there's a very good chance that there won't be a pandemic flu. But if it is, it'll be a combination of some very basic measures such as how do we have social isolation? So maybe we won't have meetings like this, we won't have schools open for a while, basic hand hygiene, basic control of droplets, you know, those basic public health measures which have been used really for 200 years can be very effective in limiting that. Then obviously, if we can stretch it out long enough, at 6 months we'll have a vaccine that should be effective. And there are limited doses of medicines, but the real preparation is going to be, using the resources we have, and some of those will be basic public health measures. And then for those people who do get it, making sure that we're able to manage with our medical system these cases very well. And I think the reason why places like Seattle are being, and it's really Seattle, New York, is because there already is very active planning and there's active collaboration between the medical community and the public health community.
You guys, I want to add on that. The public health department has been fantastic. We're on a listserv of information, so as soon as there's a case of measles in the community, a whooping cough, a meningitis, we in the emergency department know it that very morning that they put it out, because we're all in an interlinked system of information. And it's like having your pulse on whatever is happening through all of the different hospitals in the community. It's just a marvelous gift.
And you should recognize that the docs in the public health many of them are faculty at the UW, and it's sort of UW faculty there. So the reason, one reason we have a very strong health department here is that the policymakers have made it a priority, which is very important, but also having a university and a school of medicine here that is willing to be flexible and give people time to be on the faculty has really helped strengthen it, not only in the area of pandemic flu, but tuberculosis, AIDS, STD, as well as injury prevention and a host of other areas.
Yeah, last question.
Yeah, thank you. It's a comment regarding crisis in availability of healthcare for underserved populations. And there's obviously this imbalance for those of us who do have insurance and a choice. It seems to be prudent, looking at the big picture, to divert the funds accordingly to those facilities like Harborview, who do serve those populations, and I would almost say avoid for-profit hospitals if we have a choice. I don't know, would that solve the problem or just give you more people to deal with?
Well, no, I think one of the great sort of debates going on now is the whole issue of what we would call specialty hospitals. The way hospitals and physicians make money is by taking care of insured patients who are relatively well, so they don't have a lot of other diseases, and have a simple procedure that actually has a pretty good return in terms of dollars for the amount of technology and time you put in there. And the question with specialty hospitals is, what they want to do is take care of the healthy 50-year-old with no other diseases who needs to have their knee looked at, and they can go in, get the scans, get the arthroscopy or some other procedure, and leave that day, and they'll make quite a bit of money. What that leaves, though, are the individuals who have the same, say, knee problem, but they also have diabetes, renal failure, heart problems. They need to be in a full-scale hospital, such as UW Medical Center or Harborview. Those are very expensive to take care of. And so, I think it is very important for people to look at the economics. There are sort of places where you can make money, and there are places where you can lose money. But it's hospitals and, frankly, physicians who are willing to work in a system that takes all comers, the very healthy and the ones who, everybody needs to take care of some of the simple, easy cases, but also take their fair share. And I think that's the way we should look at it. Everybody ought to do their fair share. Harborview, we ought to do more than our fair share because we're sort of resourced to do that. But everybody in the medical community ought to do some degree of taking care of these complex and more difficult and frankly more expensive and less profitable patients.
And you do raise a good point in that Harborview is really dependent upon that mixture of payers and patients. So Scott, I'm sure, looks very carefully, and the hospital administration, at what's the payer mix and how many commercially insured patients do we have to keep the hospital alive and to support the mission for the underserved population. So it's great to keep that commercial mix up so that we can complete our mission.
And I should say, we work very hard, and that's why we do take care of patients from all walks of life, but our primary focus is making sure we have the cutting edge technology and the staffing and the quality, and so that a patient experience at Harborview, people come and say, boy, that's great. And I get that all the time. People come and say, yeah, I was there, and the doc was great, and the nurses were so nice, and they got great care, and so we really focus very heavily on quality.
Yeah, if I can just add something, that's what your point of view is, but we as the other side, basically, we have a choice too. So what can we do to make things a little better? I guess that was my question. Whether just avoiding certain types of facilities would perhaps encourage those to take a harder look at that.
Well, I
kind of
guess,
a public relation campaign.
since I'm the newest person here, I can go out on a limb and say that one of the things I saw at Hopkins was that the community embraced all aspects of the mission. So, the underserved, as well as people that, also sought, the best in medical care, tried to go to the medical center. And I think that as you look at the balanced things that we're trying to bring to the community, I think when I think about why am I here on a Tuesday night with you all, I think it is love to teach, but it is also to establish that relationship and that mutual support of where people come to get their health care. And so I would encourage you all to come see us, UWMC and
Pay us a
Harvard
visit.
across our system.
Thanks, everybody.
Thank you.